Hello, everyone. Today we're going to be talking about models of health service delivery and their effect on AIAN populations regarding access limitations. The objectives for this session are to 1. Outline the concept of inequity of access to healthcare for AIAN populations and the factors which contribute to it. 2. Identify redressing inequity, that is, making clinics culturally safe, employing Indigenous staff, and fostering referrals to Indigenous services. 3. Describe the historical development of AIAN initiatives, including the community-controlled sector, and reflect on lessons from these programs that can be applied in other health sectors. We will begin with a look at a historical perspective, as well as discuss the current state as it applies of healthcare delivery. Healthcare delivery to American Indian and Alaska Native, AIAN populations, is marked by a series of treaties, policies, and acts that have sought to address the needs of these communities. Sadly, AIAN people have historically experienced poorer health status than other Americans. Early history is marked by the U.S. government signing treaties with tribes between 1778 and 1868 that promised health care in exchange for land and natural resources. The U.S. Army provided the first healthcare services to AIAN people to protect soldiers and non-Indians from infectious diseases like smallpox, measles, and malaria. AIAN people were subjected to medical experimentation and forced sterilization, sometimes without their consent. In the mid-20th century, the Snyder Act of 1921 formalized the government's responsibility for healthcare and allowed Congress to allocate funds. The Bureau of Indian Affairs, BIA, administered healthcare services, but was sometimes used to implement policies that disregarded the needs of AIAN communities. In the late 20th century, the Indian Healthcare Improvement Act, IHCIA, of 1976, authorized the construction of healthcare facilities on reservations and defined the structure of healthcare delivery. The Indian Determination Act of 1975 gave federally recognized tribes more authority over their healthcare. The Indian Healthcare Improvement Act of 2010 added funding and allowed patients to access Medicare, Medicaid, and the Veterans Affairs Hospital Network. Despite its establishment, the IHS has historically been underfunded, leading to persistent challenges in providing adequate health care. Many AIAN communities continue to face shortages of medical staff, facilities, and resources. Over the years, various policy changes have aimed to improve AIAN healthcare. The Indian Self-Determination and Education Assistance Act of 1975 allowed tribes to take over the management of healthcare services, leading to the development of tribally operated health programs. AIAN populations continue to experience significant health disparities compared to the general U.S. population, including higher rates of chronic diseases and lower life expectancy. Even with these challenges, there have been periods of innovation and excellence within the IHS and tribally operated health programs. These efforts have led to improvements in healthcare delivery and outcomes in some areas. Advocacy for increased funding and resources for AIAN healthcare continues. Efforts to address social determinants of health, improve cultural competency among healthcare providers, and enhance healthcare infrastructure are ongoing. American Indian and Alaska Native AIAN populations face inequity in access to healthcare due to a combination of historical, social, economic, and systemic factors. Factors that contribute to inequity are historical trauma and forced assimilation into non-native culture that has contributed to distrust of healthcare systems. Poverty and economic adversity are major factors contributing to health disparities. Inadequate education can contribute to health disparities. Discrimination in the delivery of health services is a factor contributing to health disparities. Factors that contribute to inequity continued. Many AIAN people lack health insurance coverage. The Indian Health Service, IHS, has been consistently underfunded, limiting the services it can offer. Many AIAN people live in cities and urban areas, but IHS services are primarily in rural areas. The healthcare workforce may not be diverse enough to meet the needs of AIAN populations. AIAN people have higher rates of chronic diseases, financial burdens, and reduced quality of life. AIAN people also have shorter life expectancies than Caucasian individuals. Addressing healthcare inequities for American Indian and Alaska Native AIAN populations requires a multifaceted approach. Here are some strategies that can help. Ensuring adequate funding for the Indian Health Service, IHS, and other tribal health programs is crucial. This includes expanding services and improving infrastructure to meet the healthcare needs of AIAN communities. Healthcare providers should receive training to understand and respect AIAN cultures, traditions, and health practices. This can improve patient-provider relationships and lead to better health outcomes. Implementing policies that increase access to healthcare services, such as expanding Medicaid in states with significant AIAN populations, can help reduce barriers to care. Developing and supporting community-based health programs that address specific health issues prevalent in AIAN communities, such as diabetes, heart disease, and mental health. Expanding telehealth services can help overcome geographical barriers, especially for those living in remote areas. This can provide greater access to specialists and timely care. Improving data collection on AIAN health needs and outcomes can help identify gaps in care and inform policy decisions. This includes ensuring AIAN populations are accurately represented in health surveys and research. Tackling broader social issues such as poverty, education, housing, and employment can have a significant impact on health outcomes. Policies aimed at improving these determinants can help reduce health disparities. Advocating for policies that promote health equity and address systemic racism and discrimination in healthcare can lead to long-term improvements in health outcomes for AIAN populations. To make clinics and hospitals culturally safe for American Indian and Alaska Native AIAN patients, healthcare facilities should prioritize staff training on Native American culture and health beliefs, provide language interpretation services, incorporate traditional healing practices where appropriate, and offer culturally relevant signage and materials. Actively recruiting AIAN healthcare providers from the community will also build trust and understanding and create an environment where patients feel emotionally comfortable. Familiarize yourself with the services provided by Indian Health Service, IHS, tribal health programs, and urban Indian organizations. Establish communication with the local IHS tribal or urban Indian healthcare providers. They can guide you through their specific referral process and any necessary documentation. For services not available directly through IHS or tribal facilities, the PRC program can cover care from non-IHS providers. Ensure the referral meets PRC requirements to avoid out-of-pocket costs for the patient. The historical development of AIAN initiatives in the United States is marked by a long struggle for self-determination, primarily focused on reclaiming control over land, culture, and governance, often through the creation of community-controlled organizations across sectors like health, education, and economic development. Key points in the historical development. Prior to the 20th century, indigenous resistance to colonization primarily took the form of armed conflicts and treaty negotiations, often resulting in forced relocations to reservations and the loss of vast ancestral lands. The late 19th and early 20th centuries saw the implementation of assimilation policies like boarding schools, which aimed to eradicate indigenous cultures and languages, further eroding tribal sovereignty. The mid-20th century saw a resurgence of indigenous activism, with movements like the American Indian Movement, AIM, advocating for civil rights, land rights, and treaty rights, leading to increased awareness of the injustices faced by Native communities. The Indian Self-Determination and Education Assistance Act of 1975 landmark legislation marked a significant shift, allowing tribes greater control over their education, healthcare, and other programs, paving the way for the development of community-controlled entities. Following the Self-Determination Act, Indigenous communities began establishing their own organizations to manage vital services like health clinics, schools, housing authorities, and economic development corporations, providing culturally appropriate care and addressing specific community needs. Following the push for tribal sovereignty rights in the latter half of the 20th century, this movement was largely spurred by the devastating impacts of colonization, forced assimilation policies, and land dispossession. These events led to the establishment of the community-controlled sector as a means for indigenous communities to manage their own affairs and address critical needs within their populations. Key aspects of the community-controlled sector. Community-controlled organizations are typically governed by tribal councils, ensuring decision-making power rests with the respective indigenous communities. These organizations prioritize the integration of traditional values and practices into their services, aiming to promote cultural revitalization. Many community-controlled entities focus on addressing the impacts of historical trauma, including issues like substance abuse, mental health, and family violence. Some community-controlled enterprises focus on creating sustainable economic opportunities within tribal lands, often leveraging natural resources or cultural tourism. Consistent and adequate funding from the federal government remains a key challenge for many community-controlled organizations. Navigating federal regulations can be difficult for tribal governments and their entities. Developing the necessary expertise to manage complex operations within community-controlled organizations can be a barrier. Overall, the development of the community-controlled sector represents a significant step towards Indigenous self-determination in the United States, allowing tribes to exercise greater control over their affairs and address their unique needs through culturally relevant initiatives. AIAN populations have faced challenges with funding, resources, and policies that have led to higher rates of diseases and shorter life expectancy. However, IHS and tribally operated programs, through ongoing effort, have demonstrated innovation to move toward reducing healthcare access inequities. Strategies such as requiring cultural competency training for providers and allied health professionals, increasing the provision of telehealth services, and addressing social determinants of health and consistently referring patients to Indigenous services can close care gaps and develop trusting relationships between patients and healthcare teams. Acknowledging and respecting the role of tribal governance within the community will help healthcare leaders build positive collaborative relationships with tribal leaders to improve navigation of federal regulations and together develop the skills needed to manage complex operations. These are our references. Thank you.